unstructured documentation. To have one's cake and eat it too. So there's 3 representatives on the panel, and the first member is Dr. Ralph Cygan. Pardon? Cygan. I was looking at Despina. Dr. Cygan is the University of California, Irvine's Health Chief Medical Information Officer. He's had this role since 2007. He is responsible for all clinical aspects of the Allscripts medical record system for UCI Medical Center and the ambulatory practices. Under his leadership, the organization has had an extremely successful phased EMR implementation with outstanding physician engagement and adoption. He's also a professor of medicine and public health and a practicing general internist with particular interests in preventive health and the management of obesity. He's a member of the faculty at UC Irvine for more than 30 years and has held a number of positions in the School of Medicine and the Medical Center, including Vice Chair of the Department of Medicine, President of the Primary Care Medical Group, President of UCI's Medical Staff, and Chief Executive Officer of the Medical Center. The next individual is Lisa Dahm, who is the Director of Clinical Informatics at UCI. She's also the Director of the Center for Biomedical Informatics within the Institute of Clinical and Translational Sciences at UC Irvine. Lisa's team has implemented a clinical data warehouse to support reuse of clinical data for quality and research. She has spent 15 years as a developmental neurobiologist prior to making the transition to IT and informatics, where she has over 10 years of experience providing strategic support for healthcare and scientific informatics implementations. And the last individual on the panel is Jim Murry. He's the Chief Information Officer at the University of California, Irvine, and Associate Dean of IT and Informatics for UC Irvine's School of Medicine. Jim is responsible for ensuring that technology is helping the organization succeed in their mission of discover, teach, and heal. The Academic Health Center is ranked among the top 50 in the nation with a new 400-bed hospital facility, 60 specialized ambulatory clinics, over 600 residents, and 400 medical students. A graduate of UCI, Murry has been in the information technology field since 1974 and in healthcare since 1984. He also serves on the board of directors for the Orange County Partnership Regional Health Information Organization, a collaboration of healthcare providers whose mission is to facilitate health information exchange. So, let's go.
Good afternoon, everybody. It's a pleasure to be here, and I thank you to Lisa and Charles for organizing this wonderful event and for inviting me to participate. I think this is a really key topic for all of you that are interested and focusing your careers on electronic medical records. I think we are getting to the real hard part of the EMR implementation. I think you're probably all familiar with the HIMSS adoption model, and I think thank you for your leadership and leading your organizations up the ladder of the HIMSS adoption model. And I think we're finding that more and more of our hospitals, medical groups, are somewhere in the 4 or 5 stage of the adoption model. But when you look at stage 6, that's when we get to the really hard part. Stage 6 is the physician documentation, primarily through a structured data entry model, to facilitate the adoption of the decision support models that many organizations are trying to implement as a way of improving patient care and improving the quality of care we deliver. So I think we're going to focus today on this really hard part, this achieving that next stage of adoption in that HIMSS adoption model. So to those of you that are HIM professionals, are interested in quality data gathering and reporting, CIOs, biomedical informatics, structured data is the holy grail. You know, we should have some angels singing, I think, to accompany this. But clearly, this is the holy grail. This is what EMRs really have the potential to deliver and improve care if we can get the data structured. So by way of introduction, I want Lisa Dahm is going to talk a little bit about structured data versus unstructured data, and then I'm going to come back and talk about how physicians feel about structured versus unstructured data. So Lisa?
Thanks, Dr. Cygan. Hi, everybody. So I'm here, I think, as the token scientist. Hopefully not being set up. So I'm going to tell you a little bit, from a scientist's perspective. I have this one. I have them both on. Okay. Not good. Can everyone hear me in the back? Yeah? Okay, thanks. Okay, so I'm going to talk about the scientist's perspective of clinical data, EHR data. And to do that, I'm just going to give you a little background. The research perspective. So historically, it's been a heated debate. I think, most everyone in the room has been around long enough to know that, because by historically I mean in the past 5 to 10 years. And the debate has reflected a tension between research needs and clinician needs. And then oddly, from my perspective, on the side of research needs also comes administrative needs, from the clinical side of things. And so as a scientist, that's not usually where I find myself, on the side of administration. But actually, that also reflects, what I do at UCI. And so, my job in a nutshell at UCI is to provide data to both researchers and the administration, clinical administration. So that's to support hospital operations, to support quality and safety and performance improvement, and there was one other that I was going to say. But anyway, you get the idea. And so, I think that we've, in the spirit of Dr. Cantor's talk, I think we've evolved a little bit in the last 5 or 10 years at the speed of technology rather than biology, so that we're coming to understand and appreciate the value of both types of data, structured versus unstructured. But okay, let me get back to the scientist's perspective, though. So I'm a basic research scientist. That's my background. So I spend a lot of time in labs getting data, doing experiments, getting data, controlling the conditions under which I got the data, being able to determine how many times I repeated an experiment to get the data. So that's where I start. And so if you think of a kind of a continuum of biomedical science, biomedical research with laboratory science on one end and clinical care on the other end, where, as you pointed out, since 400 BC, it's been clear this is not the place to do the experiments over here. And then, in the middle is clinical research, and then the phases of clinical trials. That makes the continuum. Then, when I look at an EHR, I see a big candy store of data, of potential data, right? And it's like, yay, finally the data is going to come from, the paper chart where it's almost useless to me to an electronic system. And then I, as an informaticist, can take that data, extract it out, we say on the team, suck that data out of the clinical systems into a clinical data warehouse that we built just for the purpose of being able to, query it in whatever way, we need to, for whatever reason. So, everything will be there. That's the sort of the purest scientific perspective. So then, you extract the data, and you begin looking at the data in the clinical data warehouse. And Charles loves to, browse the data, and then, call me and show me, what he's found. So I'll come back to that slide. And so what we find is there's lots of data there, but it's not all the data. That's the first thing, right? It's not all of the data because, well, let me go back. Why is it not all the data? Because the data that we can extract into the clinical data warehouse is data that the computer can read. So that's sort of the simplest definition of structured data. And so not all of the data is in the EHR, and not all of it is readable by the computer. So I think everybody knows what that is. Documents, not directly readable by the computer, images, video, audio, lots of important information. Sort of the heart of clinical care almost is not available. And so then, just as a basic definition, readable, structured, unreadable, unstructured. That's sort of, the basis that we're working on right here. And so then, we're faced with a dilemma. And so the contentious argument had to do with scientists, researchers demanding that clinicians choose terminology from drop-downs or check boxes. Everything needs to be structured, available in a field so that we can, search it, we can query it, it's available. And, and then that data can be fed back to improve patient care, safety, all of that. With, not very much concern for how that affected the workflow or the care of the patients. And so that's what we've evolved away from. And so what I wanted to share with you were a few things about what we've found in looking at the data that we pull out of the EHR that's not structured. And so, obviously one of the things that everybody knows is that by allowing all of the people who are able to enter data into an EHR to enter it as free text, you're going to really increase the variability of the data quality. You're going to increase errors. I've put some examples down here. One of our favorite things, or Charles' favorite things to browse, are the list of chief complaints that come in during registration. And we have, at UCI, we have 1.5 million unique patients in our clinical data warehouse and 250,000 unique chief complaints, which I was stunned when Charles shared that with me. And then he showed me, what the variability was due to. And so, spelling errors, interesting ways to describe the way people come in, to describe what the chief complaint is. And so, we put a couple of our favorites up here. Car broke down, that was the complaint registered. And no kidneys, that's right now the top favorite. And so I'm sure all of you guys too could share, your favorites coming out of the EMR. And so obviously structured data would increase data integrity, reliability, and utility. It allows us to do things, like standardize against terminology and ontology so that we can share data between institutions. And then also, it facilitates querying and reporting as well. So that's sort of the scientist view of structured data. We're going to go back to Dr. Cygan, who's going to tell you more about the clinician's view. And we're spending more time on that as well. We should, I think.
You're killing me, Lisa. I didn't go to medical school to be a clerk and push buttons and look at drop downs. You're taking the art out of medicine. It is an art and a science. So let me tell you about the physician perspective of clinical documentation. The primary purpose is to document what you're doing, what you have done for the patient, to inform the current and the subsequent care of the patient. That's the most important thing. And to provide a means of clear and concise communication to the other members of the care team, increasingly important as healthcare becomes a team sport. It's also to support important administrative functions. Obviously, as a physician, you want to bill and get paid. You want to survive the audits of the payers, which are increasingly common. And you're also interested in improving the quality and performance of your organization. So those are certainly other important reasons why physicians document. And they want to protect their tail. They want to, in this very suit-happy environment we're in, we want to make sure that we provide the rationale for the care we've given, the justification, and prevent unnecessary and frivolous lawsuits. So that's really, I think, why physicians feel a need to provide good documentation. And physicians historically have approached documentation from a narrative, free text approach. And a lot of surveys show that the vast majority of physicians, 65 to 85%, greatly favor that historical narrative free text documentation. It has been deeply ingrained in training, it still is today, and that's what you learn, that's what you go out into practice and implement. And that approach to documentation has become very well integrated into physician workflow. It's very fast and very efficient for the vast majority of physicians. Comparing dictation with transcription to typing, it's at least 5 times faster for the average physician. Comparing dictation to point-and-click documentation is probably close to 10 times faster. So an organization tells you you're going to save money in transcription costs, you're probably going to double or triple the cost in physician time. So it's, I think it's an empty savings that's being promised. Other things about the current approach of narrative free text documentation is the reader, the user of that, is very familiar with the presentation style and organization and format. They know where to go for the information that they're seeking that's critical to the next step in that patient care. That approach to documentation encourages individuals to be succinct and put in only the most relevant information that they feel is appropriate for this patient's care and the subsequent care. And increasingly people talk about the importance of the nuanced communication, something that is a clinically rich narrative that tells the patient's story and distinguishes this patient from all the other patients with similar but not exactly the same clinical condition. So now we're going to talk about structured physician documentation. So this is a physician who's obviously transfixed by the computer screen. He's probably doing a point-and-click documentation. The patient is somewhere in the background there saying, "I'm still over here if you have any questions or anything." Not an uncommon scene in physician offices that are in the early stages of trying to adopt an outpatient EMR. So let's talk for a minute about structured physician documentation. In spite of great efforts around the country and very mature, even HIMSS level 7 organizations and level 6 organizations, the adoption rates of truly structured documentation remain extremely low. Physicians, to almost a man and a woman, find it very inefficient and tedious. It's quite disruptive to existing workflow. A lot of physicians refer to structured documentation as a physician birth control plan because because they're spending their evenings at home doing their structured documentation. They don't have time to do it during the day. Physicians will state that they're adding at least an hour or more to their typical day catching up on documentation, which is another important point. If you end up documenting everything at the end of the day, how are you going to keep the last 20 patients straight? So how relevant is the documentation that you've just done in a structured manner? I think structured documentation has encouraged a lot of sloppy work habits. Copy-paste functionality, I'm sure you're all familiar with and cringe at the thought, but it goes on rampantly with structured documentation. Cloning of notes, you look at one structured note versus the other, and they all begin to look absolutely identical. CMS is actually doing a lot of audits because they've seen this proliferation of these cloned identical notes. The habit of documentation by exception leads to some sloppiness, and the importation of too much irrelevant information. It's so easy in an EMR, structured data, just dump it all in there and hope that somebody can ferret out that nugget of truth that is in that structured document. And if you're consuming the structured documentation, if you're trying to use it, the output is not very friendly. Many people complain about it being much too cookie cutter. You can't find the key elements in a history or a physical that lacks expressiveness. Some people have described it's like looking for a needle in a haystack when you get one of these structured documents. And others have referred to them as frankly dangerous because you cannot provide the kind of care you want because you can't figure out what the previous physician has done with this particular patient. So as you can see, I'm not a great fan of structured documentation. So we've got this, balance we're trying to achieve. We all know about the benefits of structured documentation, whether it's for meaningful use, for performance reporting, for decision support, for research, all the things that Lisa mentioned. But then on the other side, you've got the important physician preferences and the important physician productivity. So right now, the balance is certainly, for most organizations, towards the narrative clinical documentation end of that continuum. So given this yin and yang situation, Mars and Venus here, what are the CIO, the CMIO, and the BMIO, that's you, Lisa, the Biomedical Informatics Officer, going to do? So at this point, I'm going to turn it over to our CIO, Jim Murry.
So, those are my customers, users. My job is to keep both of them happy. No wonder healthcare CIO's average length of job is 18 months. So, what we have is two opposing forces, I'd say here. And on the research side, as Lisa so well summarized, we have the comparative effectiveness issues that are going on, the quality of data that's important to them, and the bench to bedside. I read an article a few years ago that indicated that the effort of getting things from bench to the bedside in healthcare is approximately on average 17 years. We, as informatics people, can make a difference in that. I'm absolutely convinced of that if we can learn how to move this stuff along and give the researchers what they want and what they need. And then Lisa also mentioned clinical administration. With health reform, CMS requiring us to bend the cost curve, there's a lot of need, more than ever, for administration and clinical leadership to understand the data, what's happening in their organization, how to measure that, how to mine that data, how to use it, and then how to change things to improve their quality, which will ultimately reduce their costs. And then you have the physician that doesn't want any distractions. And the patient focus, as Dr. Cygan talked about, they don't want to lose their revenue. I mean, there's all kinds of forces already decreasing the revenue of our physicians today in the country. So here we're going to step in and we're going to help them out and make it even harder to correct revenue and to keep their volumes up. And so I wanted to share with you what I believe are two emerging technologies that are going through the evolution. So they're not completely here today, but they're on track. I think they're coming along. And one of them, I'll summarize by saying it's removing the click. So I think you mentioned the click thing is really good too, is removing that click. And so if I could with you, if we take the text and we forget about the structured data and we were to allow our clinicians to enter free-form text, that would help a little bit. It wouldn't help completely, but it'd get them out of that structured data part. Like Dr. Cygan said, it would still be slow, but it'd be faster than the structured data. And using natural language processing today and technology wrapped around that, there are very capable technologies that allow you to extract the information and convert that to structured data. And working with your EMR vendors, you can basically populate that into your EMRs. So there's a way to take free-form text with these emerging technologies and move that to structured data. The next part is voice recognition and moving that to text. And that's really matured in a clinical setting over the last few years, and we're testing some of this now, and very strong possibilities with it. So if you take a free-form text box and you were to talk to it instead of type into it, and then have that be converted to text, and then from that to the natural language processing engine, and then into the structured data, you now have a model maybe where physicians have removed themselves from the keyboard and the clicking. And if I could give you like a little example of this, it's not here today, again, evolving, and this is from a patient's perspective because I'm not a clinician, so I'll give it to you as my view as a patient. I go in for a physician appointment, and they put me in an exam room, and they put that paper chart in that little thing in the door outside, and the nurse comes and grabs it and walks in and does some things and asks me some questions, and she or he puts that back on the door, and the physician grabs it and goes back in and works with me and put it back on the door, and they're done. So what we want to do, I mean, really, have a real successful EMR implementation is you don't have adoption to a new cultural change. We want to leave the physicians into the mode that they're used to working in. So I'll just hypothetically, let's say that there's an iPad in that little slot instead of a paper chart. Nurse picks it up, walks in, asks some questions, does her stuff, his or hers, puts it back on the door. I'll go through the physician one in more detail. Physician grabs it, walks in. Maybe it's on one of those ones where you have the little sleeve in the back and you put your hands and you can kind of hold it like this. And you sit down and you're talking to the patient. And, you know, I skipped something here. The EMR narrative to voice. Let me back up, I'm sorry. But the other part of the voice recognition is what if we could navigate the EMR through voice? Hey, bring up patient Jim Murray and bring me to the latest lab results. Okay, so now back into the room with the patient. So you've got this thing, you're talking to the patient, sitting, standing, you're talking maybe to your iPad, please bring up the latest results of this or bring up this or whatever, and then you want to do some notes, and you say, history, and you just talk. And maybe you want to show the patient some information, so you have a big 30-inch screen up there on the wall, and you do kind of an Apple TV thing, and you throw the image from your iPad up into the monitor, and then you kind of share with the patient the information that you want. You're done, you put the thing back in the door, and you walk out, and you're right on schedule. Then later on, you sit down with the system, maybe at a desktop, and it brings you up, and it shows you what it was able to populate and what it couldn't populate, and you kind of correct it and you fix it. And what I've learned, and I've been doing EMR implementation since 1984, and what I've learned is physicians basically will resist this with every fiber in their body of implementing EMR. But when they finally get it and they finally engage, they learn so fast you can't even keep up with what they want to do with it. And my bet is if this technology were to work, the physicians would learn what they had to say and how to say it. So in a month or two, they would sit down and edit hardly anything. That's just my bet on that. So there's an example, I think, of where some of this technology can go. The second form is the area around big data, or free-form text. So Google, Facebook, and the latest one that I've been really impressed with, and I've been talking to IBM, is their IBM Watson system. Everyone know what the Watson, okay, the Jeopardy tool, phenomenal engine that just sucks up a bunch of information. And they had two goals in mind with the Watson technology. One is we wanted a response within 2 seconds, 2 to 3 seconds. And the other one is we wanted a percent factor of the probability of the answer being right or not. And based on that response in 2 to 3 seconds and their probability, they would decide whether to say, hey, I want to answer the question or not. So if you think about that technology and you think about moving patient data, your patient data. We've got this free-form stuff going, right? We're sucking some of it out and we're putting in structured data. But what if we just gathered all that free-form in a great big data thing, right? And we could search that, like some of these tools could do today. So it brings the four thoughts to me right away. One is I can get the data that I didn't know I needed yesterday. So give you, for example, CMS has always come and say, you know what, you're capturing that data, but tomorrow I want you to start capturing this kind of data. Well, with this kind of technology, we just might be able to go back and capture some of that data. Additional resources for your data, for your SQL, your structure, your database. So now you have an alternate method of getting to data along with your database structure to do things. Solving the standards, the data standards problem. Those of you that have been in IT, one of the biggest pains in the butt challenges that we have is standardized data. Now, I might capture all this structured data in my organization and all my tools are working fine, but what happens when the government says, we want you to share that with everybody else in the state of California? My standards, my data structures are not going to map to the rest of the state or the country or whatever. With the big data concept, you don't necessarily need this. So interesting, maybe, interesting things to think about. And the last one is suggestive analytics, and this is the Watson idea. What if I had my personal data in there, like in my EMR in this free-form big data thing, and I could connect it to some national thing that had all this literature, this clinical literature that our physicians can no way read all of it. It's all in there, and it bounced your personal data with that data and came back with maybe suggestions or things for our clinicians. So I think those are possibilities with that type of technology. When you put those together with the front end and creating the free structured data and this back end, I think we have some interesting opportunities and maybe a paradigm shift in the way that EMRs are implemented. And I'll end by just one last note. We work with a lot of medical students at UCI. Very exciting to work with them. And we've been implementing technology. We now produce their entire curriculum on an iPad. When they come in their white coats, we hand them an iPad and their entire year's curriculum on that. And working with them, I thought the adoption of the EMR would be like really good because I've given up on existing physicians. I thought, let's go attack the students because there's no hope for physicians. You know what I found? I found that the EMRs are so far behind in what they bring to the user interface that the students can't even tolerate it. It's like this is not acceptable user interface technology. So we have a long ways to go in this. I think this might be a part of the beginning of that.
You guys ready for some questions?
Sure.
All right.
You guys take them.
So, thank you guys. Sharif Tarman from Chalk and Pediatric Neurology. I got two questions. One's for Jim Murry and the other one's for Dr. Cygan. For Jim, the comment first. Watson, they've been using in a pilot program to look at cancer data, and I can't remember where it was, somewhere on the East Coast, to look at the cancer data and try and tell physicians, look at this or that and see how it works out. But one of the things that I think physicians want to use is sort of a search on the patient, not just a search on all the patients. So I want to see one of my patients say, okay, show me all of the things related to neurologic problems. And it'll pull out ADHD, seizure disorder, whatever the patient may have had from all the people that charted. So that's kind of how do you feel that is coming, and not so much of a look at all of the patients, but patient-specific. And then my question for Dr. Cygan is, how about a hybrid model? So I dictate a little bit through something called Hotspot. I structure a little bit, such as macros. And I think that, at least in my perspective, works pretty well. And do you think that that's something that's realistic?
To the first question, absolutely. I think that is another absolute possibility, probably more useful and probably will come out first before some of this population kinds of things.
Yeah, hybrid documentation. I actually am not a total structured data Luddite. I do believe that structured data is important. And actually the implementation that we're doing, which is kind of a gradual, involves a lot of structured data entry already. Patient medication lists. We've had wonderful adoption. Obviously, that supports electronic prescribing. So we pretty much have all of our physicians or their physician delegates putting in structured medications, the allergy lists. We've had pretty good adoption of the problem list using ICD-9 coding. So we have patients with problem lists as long as your arm, and you could search for all of their neurologic diagnoses if that was the type of thing you're looking for. You can create patient lists off diagnoses. So I think clearly structured data there's lots of opportunity, and I think physicians are very accepting of certain types of structured data entry. But the HPI, the assessment and plan, I mean, I just don't think that structured data lends itself to that particular part of the EMR. The other thing I think about structured data is every piece of structured data doesn't have to be entered by the physician. And one of the things that we're doing is to try to look at the entire workflow of the patient and to say, okay, here's a piece of data that we need, and who is the most appropriate person to collect that piece of data? And in our ambulatory clinics, we're finding that our medical assistants are perfectly appropriate to collect certain types of data, nurses in the hospital, and other types of data. And so as we decide this is a piece of structured data our organization values, we're going to look carefully at who is the most appropriate person of the healthcare team to put that data in the chart. So, and I think that's a perspective that's going to be really important going forward. Is not put it all on the shoulders of the physician, but to really look at the workflow.
This is a great topic, Ben Cantor, Palomar Health. From a physician standpoint, there's probably nothing that would engage physicians more than talking about this sort of thing. And one issue that you all face with any kind of EMR conversion is that you probably had different processes on different floors and different expectations. A surgeon's note looks radically different than my critical care note. And as you move towards ICD-10, or as you start going into discharge planning and discharge documentation, you have to start to standardize and standardize your expectations, which is a very difficult change management. But I'll leave that piece alone. We put in structured documentation in our ED probably 3 years ago now. And after 9 months, we had to put in voice recognition for the HPI and the assessment piece. We had to move to hybrid because we just couldn't gather the nuanced documentation on the receiving end. And we're fine now. So that was a very big help to us. One of the things, Lisa, that you pointed out, yes, you can use the structured documentation for research purposes, but there's another big piece of it. And that is triggering ongoing clinical decision support real-time based on what you're documented, obviously, and then being able to take information like what Nuance is doing with 3M and IBM, take that information and get my MedRec home medications into the chart. That's a huge chore, whether you're using pharmacy techs or nurses to put that information in. We have to document it as part of our HPI. Why can't it just go right into the record at the time? So, that's really what we'd like to see. Last thing, once you move to electronic documentation, whether it's structured or not, this bit about copy and paste and note cloning is enormously important. And I think that for us, we haven't gone to structured documentation or electronic documentation yet. And I'm trying to convince our medical staff we're going to actually have to have more oversight of that than we did for CPOE. Just to let everybody know, there's a very good white paper on this from AMIA, and I think it's 2008. It's their copy and paste toolkit. It's the best document I've seen on this thus far. But AMDIS, there's a group of CMIOs, Joel Shulin at Advocate in Chicago, among others, are creating a white paper right now on a national approach to electronic documentation for physicians. So that will be very helpful for all of us, I think.
Charles?
Question?
I'll say one. Nice debate, guys. Very cool. So, tell me about the problem with the problem list. I think a lot of times we put the burden of discrete data collection on the physicians when we should be collecting that from other more discrete sources and lab instrumentation and other ways of measuring, and leave the analog waveform process to the physicians rather than the digital process. But the problem list is a classic example, and I'll give you the story at Northwestern. When we were analyzing all the discrete values in the problem list, we came across Jehovah's Witness. And it struck us, well, how can that, what was the mindset behind that as being a problem? Well, of course, there are, religious issues associated with treatment and care of Jehovah's Witness. And the physician chose to list that for no other place to put it as a discrete form in the problem list. But anyway, I'd love to hear your thoughts about the problem list and what role it plays.
Yeah, the good news is we have really good adoption of the problem list. The bad news is we have really good adoption of the problem list. So a lot of stuff gets in that problem list that perhaps a discerning physician that has a long-term relationship with the patient may feel is noise in the EMR. But, we've got all of our different practices, specialty, primary care, super specialists, they're all putting in their problems. So it's been recommended that one of the primary care physicians' roles is problemless reconciliation, believe it or not. Just like somebody has to reconcile the medication list after a while because it gets a lot of junk in there, I think the problem list needs to be managed. I'm not sure it's going to be a reimbursable task, but it is ultimately, I think, an important task. And we're already seeing some of those issues.
Do we have any other questions?
So Charles, I had a comment related to problem lists. So we're doing several initiatives at UCI with data sharing. One of them is a cross UC data sharing initiative between the 5 academic medical centers. And I sit on a couple of the working groups for that project, and one of them is the data harmonization working group. And one of the big items for discussion in that working group is where do we pull diagnoses from for sharing, right? And so the two choices are the billing system. ICD-9s are in there. They're nicely coded. Wonderful to look at. But then, what is the relevance to the actual, clinical condition? Is it a clinical diagnosis or a billing diagnosis? It's a billing diagnosis. And so then the other source is the problem list. And so, the problem list is problematic in the way that, you both described, very, very nicely. And so, I think this idea of problem list reconciliation would, go a long way towards allowing us to be able to pull more clinically relevant information, out of the EMR to use in, with the billing data. And also even to do analyses, to compare, what the billing diagnosis was compared to the clinical diagnosis to see how far off they are.
This is Jamie Anand, UCI, and we just implemented also a patient portal. So now the patients are starting to see the structured problem list, and I actually get quite a few calls from our patients that are talking about the fact, what do you mean I have ED, erectile dysfunction? And then I go on and I look onto their medication list, and there's certainly medications there that elucidate the fact that there may be a problem. And we've actually even had some patients who've said that, how do I get problems removed from my problem list? Because I disagree with the fact that some provider has identified me as having this particular problem. And obviously, many of our patients, recognize, if you're fat, you're fat. But sometimes people know that, another problem in one provider's perspective may not be the same problem in another provider's perspective. and there might be two problems that are identified. And I think the concept of a problemless reconciliation is really going to start having fruition when pretty soon with patients in meaningful use stage 2, patients are going to be at the center of their structured data.
Just a comment for those of you who are trying to do problem list reconciliation. Both UC Davis and UC San Diego have gone back and got the book by Larry Weed from 40 years ago, who's the father of the problem-oriented system. And there's a lot of good stuff that was worked out 35, 40 years ago.
Okay, thank you. We're going to go on to the next. Thank you, UCI.
Okay.
Oh, Doctor.
Yeah. Shut this off, yes.